in 30 seconds, Mr. Kazi.
Right. Would you give me a count or I'll start?
Yeah, I will count down. Yeah, 20 seconds. Ten seconds. 5. Please start, Mr. Kazi.
Good evening. On behalf of Acumentis, we are part of Akums Group in India. We are a conglomerate which manufactures to the extent about 13% medicine which are consumed in India, and Acumentis is a subsidiary. Acumentis is known for its various marketing divisions. Today, I represent the Noveltis division, which is a part of cardiology and diabetology segment. And we look forward for supporting the physicians in India and getting a lot of platforms such as this is ACC Konnect, so that we take it forward the next level of discussions around the chairpersons and a very august gathering which we have here. So thank you so much for being with us. I would like to introduce Dr. Jamshed Dalal, who is the Director of Cardiac Services, Kokilaben Hospital. He is the first chairperson. Dr. Dhiman Kahli, who is the Director of Interventional Cardiology, B.M. Birla Hospital Research Center, Kolkata. And of course, Dr. S.S. Iyengar, who is Interventional Cardiologist, Manipal Hospital, Bangalore. With this, I would request Dr. Jamshed Dalal to introduce Dr. Andrew Coates and set the context for today's evening program.
Thank you very much. Could I please have the introductory slide of Dr. Coates, please? Yes. So welcome, Dr. Andrew Coates. We are very happy to have you speak to us, and there is a large number of doctors on the audience waiting to listen to you. Dr. Andrew Coates is the president of the ESC Heart Failure Association. He's the director of the Monash Warwick Alliance and the academic vice president of the Monash University, Australia. Of course, we all know about Dr. Coates. I've read so many of his articles, and as you can see, he's originally, of course, from UK, having done his doctorates from Oxford and Imperial College. He was appointed as the professor of cardiology at the Imperial College as early as 1996. As you can see, he has got multiple fellowships and involvement in multiple societies, both in UK and in Australia. And of course, lots of papers, lots of publications, almost 50,000 career citations, multiple textbooks. So really, we couldn't have a better person to talk to us about these various aspects of heart failure, hypertension. What Dr. Coates is going to do is today to go over the ACC 2022, which has just been presented very recently in USA. So he's going to take us through a number of trials and tell us what, very briefly, of course, because he has to cover so many trials in a period of half an hour. And after that, along with Dr. Kale and Dr. Iyengar, who will be asking questions or talking and giving their view as well. So thank you very much, Dr. Coates, for being with us, and over to you for your presentation, sir.
Thank you so much. It's my great pleasure to present. Pity we can't be with us in person, but we're all used to that now. So let me just share my screen. And I just need to make that full screen mode.
Down right, so yeah, that's right. Yeah. Yes, great. We can see it very well now.
Okay, so here are my declarations at the bottom. I'll talk about the highlights from ACC 2022 that's just been completed. First of all, there was the first demonstration of a new major international guidelines, that of the management of heart failure from the ACC-AHA HFSA. And it's important to compare and trust that to the previous international guidelines published by the ESC in September last year. The central algorithm has some interesting aspects I'd just like to highlight. Like many recent guidelines, there are now recognition of the 4 foundational drug classes that are given to all patients with HFrEF equal to or below 40%. You see here with a strong preference for ARNI in class NYHA class 2 to 3, but the possibility of ACE or ARB as an alternative if ARNI isn't tolerated. Then, of course, beta blockers, MRAs, and SGLT2 inhibitors. No preferential order for starting those, and of course, diuretics as needed for fluid control. Then importantly, there's a step 2. So you go from left to right as the progression of treating the patient. Step 2 is patients whose ejection fraction thereby improve and go above 40%. That's now a new group called heart failure with improved ejection fraction. They need to continue their guideline-directed medical therapy, but they obviously don't need any further progressive therapies. Then patients who remain symptomatic, remain with a low ejection fraction, can be considered for other treatments such as hydralazine nitrates in African Americans, Black subjects, ICD, CRT, and other additional therapies. And they can be considered later on, particularly in patients with advanced heart failure, where of course there's mechanical circulatory support, transplantation or palliative care, and investigational studies. There's a recommendation about guideline-directed medical therapy dosing, sequencing, and up-titration, and this is a really hot topic now. It's in the past, we had the historical order of starting an ACE inhibitor, then a beta blocker, then an MRA, and then other treatments. We're now suggesting the 4 foundational drug classes are all commenced relatively quickly as it's safe to do so. And people are no longer giving a specific order in which the drugs need to be started. So the recommendations here is that in patients with HFrEF, titration of guideline-directed medical therapy to achieve target doses is recommended. And there's a further comment that the speed can be accelerated. So they talk about in patients with HFrEF, titration optimization, up titration can be done as frequently as every 1 to 2 weeks, depending on the patient's symptoms. That's really a first suggestion. It's not evidence-based, it's based on expert opinion. And many people actually feel that you maybe even could start more rapidly than that. Although no one's at present is suggesting that the 2 or 3 or 4 medications are started on the same day, there is a suggestion that quite a few can be commenced during an acute admission for heart failure hospitalization. Then there are recommendations about what to do during a hospitalization phase, such as pre-existing guideline-directed medical therapy should be continued and optimized. If you have just mild decrease of renal function or asymptomatic reduction of blood pressure, you should persist with guideline-directed medical therapy and not routinely discontinue. One exception for that might be SGLT2 inhibitors in patients who are hypovolemic or unwell. In patients with HFrEF, GDMT should be initiated during hospitalization after clinical stability is achieved. So the ideal time is 1 or 2 days prior to discharge. And in patients with HFrEF, if discontinuation is necessary, it should be reinitiated and further optimized as soon as possible thereafter. There are specific recommendations for ACE, ARB, and ARNI. And for the first time, there's a 1A recommendation preferencing ARNI over the other 2 alternatives in this drug class. ACE inhibitors are only recommended in patients in whom ARNI is not feasible. That's not exactly described, but presumably it covers intolerance, but maybe also affordability issues. And in patients who are not tolerant to an ACE inhibitor and the ARNI is not feasible, then ARB is the 3rd choice for this drug class. And here we pull out the specific recommendation for ARNI, also a new recommendation in heart failure with mild to reduced ejection fraction, HFmrEF. That's people with ejection fraction between 41 and 49%, a class 2B recommendation for ACE, ARB, or ARNI, and a class 2B recognition for ARNI alone in patients with HFpEF, ejection fractions equal to or above 50%, that reflects the FDA indication for this agent in HFpEF. Although there is the proviso, it's recognizing that the evidence is stronger if the ejection fraction is below normal, although it's not exactly defined what the lower limit of normal is. Most people think that's around 57 to 60%. The next is changing gear. It's an interesting long-term follow-up of a randomized trial of renal artery denervation presented by Felix Mahfoud from Germany. And the objective, after previously reporting on the 6 months results on blood pressure levels of renal artery denervation versus, importantly, sham control procedure of the first 80 randomized patients in the spiral hypertension on med trial. In this final analysis of this population, they compared changes in blood pressure, use of antihypertensive drugs, and safety out to 36 months. The design is shown here, randomized control between sham control and renal denervation, with assessments at 3, 6, 12, 24, and 36 months. Patients had elevated office blood pressures and elevated 24-hour ambulatory blood pressures with systolics between 140 and 170, stable on 1, 2, or 3 antihypertensive drugs for 6 weeks. The results are shown here. Well, first of all, the number of medications was similar between the RDN and the sham groups, but the medication burden was lower in patients randomized to renal denervation, and that presumably reflects the lower blood pressure. There is less need for titrating the dose of antihypertensive medication. Change in 24-hour systolic blood pressure, which is probably the most accurate way of assessing blood pressures, certainly far more reproducible than office, showed a reduction in systolic blood pressure. At 3 months, there was a trend. It was significant at 6 months, minus 9.3 compared to minus 1.6 on sham control. And that continued with further widening. So the reduction of 18.7 at 3 years compared to minus 8.6 on placebo, highly statistically significant. So the difference is maintained. It's seen at 6 months and progressively increases with really very significant control measures of systolic blood pressure. If we look at other ways of assessing the blood pressure, you see the average 24-hour systolic blood pressure is highly significant, as is the morning systolic blood pressure, the daytime average systolic blood pressure, the nighttime average systolic blood pressure, and the office systolic blood pressure. Although to reflect the poorer reproducibility of measurement, that's the only one that wasn't significantly affected. So I think this is really quite powerful and convincing long-term benefits on blood pressure of renal artery denervation. In terms of safety, there were really no safety signals of concern. You see there just 1 or 2 side effects across both groups. In conclusions, radiofrequency renal denervation compared to sham control demonstrated clinically meaningful blood pressure reductions. Given the long-term safety, it provides an adjunctive treatment modality that's a possibility for the management of hypertension. And these results are specific to the form of renal artery denervation used in this trial. Next, changing gear again, this is a treatment trial of obstructive hypertrophic cardiomyopathy, a condition that we've had very few major clinical trials, but now we're beginning to see the first evidence of good outcomes from drug treatment trials in this condition. This is the results of the VALOR HCM trial, and it's looking at a myosin inhibitor with the endpoint of deferring surgical myectomy or alcohol septal ablation in obstructive hypertrophic cardiomyopathy. We all remember obstructive hypertrophic cardiomyopathy is a condition that's associated with significant symptoms and a high risk of death. Alternatives include septal reduction therapies, either surgical myomectomy or alcohol ablation. These, however, are quite invasive procedures, carry some risk, and there is a clear unmet need for non-invasive alternatives. Mavacamten is an interesting new agent that's almost like the flip side of omecamtiv mecarbil. It reduces the number of myosin-actin cross-bridges, which attenuates the hypercontractility of we see in obstructive hypertrophic cardiomyopathy. That can lead to improved compliance and energetics in the myocardium. It's a targeted inhibitor of cardiac myosin. The design of the study shown here, 112 patients randomized to mavacamten, one of 4 different doses, or double-blind placebo. And you see there that there is a starting echo, stress echo, and evaluation for the need for septal reduction therapy with assessments of 4 weeks, 8 weeks, and 12 weeks, and a final end of study visit at 16 weeks. The core lab echo, LVF, and LVOT gradient were measured at rest and during the Valsalva maneuver. The primary endpoint shown here, highly statistically significant. You see that many fewer patients, 17.9% compared to 77%, required a decision to proceed to septal reduction therapy by week 16. If we look at NYHA class improvement, and we look at patients who improve by 0, 1, or more than 2 NYHA classes, we see a significant benefit of the mavacamten group, with more patients improving NYHA class over on the right. If we look now at the left ventricular outflow tract gradient at rest and during the Valsalva maneuver, we see the resting and Valsalva on the right. We see both a progressive reduction in the severity of the outflow tract gradient, both resting and under Valsalva maneuver, by the use of mavacamten. You see there the gradients go from an average of around about 51 down to 14 on treatment group and 28 during Valsalva maneuver. If we look at safety and secondary efficacy endpoints, ejection fraction, very little change there. The difference is -4% from a very high 69 down to 65, which of course clinically probably reflects a beneficial effect in hypertrophic cardiomyopathy. The KCCQ, which is a good, probably the best validated score for heart failure symptomatic severity, showed a substantial improvement, a 13-point difference of score with an elevation of score in the treated group. Secondary efficacy endpoints included N-terminal proBNP and troponin I changes over time. You see there a reduction in N-terminal proBNP, highly statistically significant trend for troponin, but no real difference. And adverse safety effects, interesting one is there were 9.1% of patients getting non-sustained VT on placebo, 0 in the mavacamten group. Clearly, that wasn't powered to show that difference, but that's an interesting observation. In conclusion, in obstructive hypertrophic cardiomyopathy patients with intractable symptoms referred for surgical reduction therapy, administration of the novel cardiac myosin inhibitor mavacamten titrated using echocardiography led to a reduction in need for septal reduction therapies, and positive secondary endpoints, all highly significant, including a reduction in LV outflow tract gradient, improvement in NYHA class and in KCCQ, as well as reductions in N-terminal proBNP and troponin I levels. Next, a different study now turning to heart failure, and this is use a novel potassium binder, patiromer, with the intent of seeing if it could improve the use of an uptake of RASi inhibitor therapies and doses in patients with HFrEF. I'm a member of that steering committee as well. So patiromer is a novel potassium binder that's a non-absorbed cation exchanger that exchanges and takes up potassium, thereby reducing plasma levels of potassium. Prior trials have suggested patiromer may also enable RASi use by reducing potassium levels and reducing the incidence of hyperkalemia. Experience in heart failure was, however, limited. So the DIAMOND trial was designed to assess whether patiromer in HFrEF, with a current documentation of hyperkalemia or a history of hyperkalemia induced by RASi therapy, can simultaneously control potassium levels and enable more optimal RASi therapy and thereby improve clinical outcomes. Here's the design. You see the patients went through an open label phase. First of all, they came in either being hyperkalemic at the time or with a history of hyperkalemia, but normokalemic at the time, having previously had a RASi dose reduction due to the hyperkalemia. There was a single blind phase of patiromer active, during which attempts were made to optimize, increase the dose, and commence MRAs, ACE inhibitors, ARBs, or ARNIs. Then at the point of randomization, the treatment was changed to double-blind, either continuation of patiromer or conversion to placebo, which of course meant the potassium binder was removed, which may have allowed hyperkalemia to recur. And then potassium levels were monitored, as was the use of RASi doses, as was other clinical outcomes. 1,642 patients to screen, ultimately 439 versus 439 randomized, and 414 and 417 completed double-blind study. This trial was affected by the COVID era due to many sites being closed, patients unwilling to come, so the ultimate size was reduced. So there was a modification of the endpoint to have the primary endpoint being converted to measurement of serum potassiums rather than overall clinical outcomes. The trial was positive, showed there was a significant between-group difference in serum potassium levels, shown here. The difference was relatively modest in size, 0.1 milliequivalent per litre. However, it was maintained consistently over the trial. If you look there at by week 1, we're having a significant effect, and that was maintained throughout the study period up to beyond 1 year. In terms of subgroup analysis, there was no difference in the different potassium between patients who came in with hyperkalemia versus a history of hyperkalemia but normokalemic in outcome. Also no difference in terms of patients by age, gender, geographical region, median ejection fraction, NYHA class, or N-terminal pro-BNP level. There were other endpoints, and they included a win ratio, which is a way of assessing whether patients were better by effectively comparing every patient on patiromer with every patient on placebo and see whether patients had a better clinical outcome if they were randomized to patiromer. That composite was a significant benefit, and it included things looking like cardiovascular death, all-cause death, time to first cardiovascular hospitalization, total number of cardiovascular hospitalization, heart failure hospitalizations, as well as MRA discontinuation and dose. You see here that significant effects were seen. There were fewer patients who had an MRA dose reduction or discontinuation or serum potassium level above 5.5. In conclusions, the majority of patients, nearly 85% with HFrEF and RASI-related hyperkalemia, could achieve optimal doses during the open label patiromer phase, including introduction and use of MRA when treated with a potassia, while still maintaining normal serum potassium levels. Then during the double-blind phase, patiromer treated maintained lower serum potassium levels with a consistent difference of about 0.1 milliequivalent per litre. Patiromer use was associated with a lower incidence of hyperkalemia events, reflected as episodes of hyperkalemia or hospitalizations associated with hyperkalemia, and a greater proportions of patients being maintained on MRA at target doses according to guideline-directed medical therapy guidelines. The win ratio for hyperkalemia-related events, accounting for mortality and morbidity, and overall RASI use score were both significantly higher with patiromer treatment. So the implications is that we can potentially now overcome a failure to achieve optimal RASI therapy because of hyperkalemia by using a novel potassium binder patiromer. And this is now given a general recommendation in new guidelines, although it's not given a strong numerical guideline. It's mentioned as a possibility. We expect to see more interest in this in the years to come. Next, I'd like to talk about the SGLT2 inhibitor empagliflozin, which of course has been subject to 2 major trials, EMPEROR-reduced in HFrEF and EMPEROR-preserved in HFpEF, both of which were positive for major composite clinical outcomes. This is now an extra trial, a smaller trial, but a very interesting one, the EMPULSE trial, because it looked at patients still in hospital after an acute admission for heart failure. It's, if you like, the missing link in the SGLT2 inhibitor trial family. We have EMPEROR-reduced of HFrEF with empagliflozin, DAPA-HF in HFrEF with dapagliflozin. We have the SOLOIST trial, which has a slightly different agent, sotagliflozin, in acute heart failure in patients all have had type 2 diabetes. And we have the EMPEROR-preserved of empagliflozin in HFrEF. Now we have the EMPULSE trial, which was done during an acute hospital admission for patients with either HFrEF or HFpEF, either de novo, new onset heart failure, or acute decompensated heart failure with or without concomitant type 2 diabetes. Patients were recruited during an acute hospital admission. 530 were randomized worldwide. And they were assessed then at multiple time points, day 1, 15, 30, at 90, by the KCCQ, Kansas City Cardiomyopathy Questionnaire, Quality of Life Questionnaire, and then further follow-up after that. The median time from hospital admission to randomization is 3 days. That allowed acute recompensation, but the patients were still relatively acute in their hospital stay. The main results was also another one of the win ratios I referred to. That's an increasingly used clinical trial outcome, but still one that's not very familiar. In it, you compare every single patient randomized to active to every single patient randomized placebo, and you line up major outcomes and see whether those patient pair comparisons favored the active treatment or the passive treatment. The result of this was highly significant, p.0054, and it's defined as a win ratio. How many of those pairs of patients was the patient randomized to the active doing better than the placebo? And there was a 36% greater chance of winning if we were randomized to empagliflozin compared to placebo, which is obviously the beneficial thing. And that was statistically significant. The endpoints were made up of patients who died, patients who had heart failure events, KCCQ total symptom score, and a very small percentage of patients who had no episode. There were so-called ties. You see, for each of these endpoints, there was a preference in favor of empagliflozin being the winner. And overall, in 54% of patients, the paired comparison showed the EMPA patient did better than the placebo, and in only 40% of patients did the placebo patient better, and in 6.4% of cases, there was no winner. So that was a highly important, clinically important result. If you look now at the KCCQ results, you see the overall benefit shown here. This was the primary hierarchical composite endpoint stratified by symptomatic severity. And you see, based on tertiles of KCCQ, you get a same benefit. So it seems to be benefiting patients irrespective of the severity of the symptomatic limitation. The KCCQ results shown here with a dramatic increase, as you expect, in patients recruited during acute hospital admission, but there's still a significant difference between EMPA showing superiority over placebo during longer-term follow-up. And that's also seen in the various measures from the KCCQ, the overall symptom score, the clinical summary score, the physical limitation score, and the quality of life measure. In terms of responder analysis, that's looking at the percentage of patients who improve by a certain amount in KCCQ or who deteriorate. You see that there's a strong trend for fewer patients deteriorating by at least 5 points if randomized to EMPA, and a strong trend for more patients improving at 90 days, either by at least 5 points, 10 points, or 20 points, all suggestive of a relatively quick and important improvement in quality of life. So in conclusion, treatment with empagliflozin produced total clinical benefit by the win ratio amongst patients recently hospitalized with acute heart failure across the entire range of severity of KCCQ limitation. That indicates the benefits of empagliflozin in this patient group are independent of symptomatic impairment. It also improved all the key KCCQ domains, including symptoms, physical function, quality of life, and social functioning, and it's consistent across demographic and clinical characteristics as early as 2 weeks after initiation. So I'd like to stop there, but I look further for further questions and answers and discussion with you all. Thank you very much.
Thank you very much, Professor Coates. That was a beautiful summary of the ACC meeting. I just give my comment for a moment before we move on to the other chairpersons. I thought the heart failure guidelines were beautifully done, and the charts which they've shown for reduced, mildly reduced, preserved, and for recovering were excellent guidelines in very simple charts, and I think that's very useful. I thought there was no really sort of path-breaking trial that was really presented, in the sense that none of these trials would actually change the course of treatment and make something class A1. So I didn't think any of the trials were really that path-breaking as we have seen in the past, not like an ARNI trial or a first SGLT2 trial that we have seen. I was extremely impressed by the mavacamten because I think for first time now we have some actually medical therapy for mavacamten. It's not available with us now. We'd like to know if you have personal experience with the drug as well, Professor Coates. Do you have any personal experience with the use of mavacamten, and is it commonly used in UK or in?
No, it's not. It's not approved in any of the jurisdictions. So it's still an experimental clinical trial only drug, but it does look a very exciting prospect.
Yeah. So I'll request Dr. Dhiman Kale to give his views on it and ask any questions. Dr. Kale, over to you, please.
I totally agree with you, Dr. Jamshed Dalal. And first of all, congratulations, Dr. Andrew Coates, for beautiful elucidation of all the trials in a beautiful way so that we can gather further knowledge after the ACC. Regarding the, this heart failure with reduced ejection fraction, it was probably I saw that ARNIs are not recommended in NYHA4, but ACIs are. Any comments about that in the ACC guideline on heart failure?
Yes, I mean, I guess people haven't really pulled that out, but ARNIs really had, it's only had trials in recent times, 5 or 6 years, and they've been restricted. There's only been one trial that's looked at more advanced heart failure called the LIFE trial. That was affected by COVID, was stopped early and didn't have a significant benefit. So we don't really know anything about the use of ARNI in severe heart failure. So we have mainly the Paradigm study and some smaller studies, Pioneer and Prove, and they didn't include such severe cases, which is why technically they're saying now the evidence is task 2, 3.
Important. Yeah.
Also, one must remember that when you come to the end stage of heart failure, this is a discussion we had because after the LIFE trial was presented. And the fact remains that when you're on the end stage of heart failure and you're really in the last phases of heart failure, you need some amount of RAS stimulation and some amount of sympathetic activity to keep you alive. So as soon as you start blocking all that, the patient's going to deteriorate in terms of fall in blood pressure, creatinine rise. So I think you can treat up to a point, and beyond that, all these sympathetic activity actually keep you alive. So I think you can't push drugs beyond a point.
This is in contrast to, Jamshed, of carvedilol in the Copernicus trial. Because if we remember the Copernicus trial, the patients were all in NYHA4 class, and the average ejection fraction, mean ejection fraction was 25%. So they're a very bad group of patients so far LVF is concerned, and the NYHA4 patients, but they did extremely well, and there was a significant reduction with carvedilol. So we find that there is a little difference between this ARNI so far as the ultimate result is concerned. And there was any mention, sir, about vericiguat. ESC has given vericiguat and digoxin both class 2A indication. Was there any mention about that in the ACC recommendation for heart failure regarding vericiguat?
Yeah, just a few comments. Yeah, vericiguat's down there just as an alternative if needed. The issue with vericiguat in the Victoria trial is the results were beneficial, but there was no effect on mortality. It was all heart failure hospitalization. But the only slightly difficult bit was that divided by N-terminal proBNP, the highest quartile had no benefit. In fact, it was even trending to a harm. So you might want to consider it for patients who are most sick in terms of recurrent heart failure hospitalization, but you shouldn't give it in the most sick in terms of elevated N-terminal proBNP. With regard to carvedilol, I was actually on the Copernicus study, and they were severe, but we didn't include patients with acute decompensation, and we actually didn't classify them by NYHA class. So they were probably mostly class 3B. I'm not sure that we'd call any of them class 4. It was more advanced stage 3, but definitely no congestion at the time of randomization.
I think that is valid for initiation of therapy with beta blockers in any of the patient, because unless the patient is euvolemic, the patient is able to tolerate the beta blockers. We don't, in the CBIS2, in the MERIT-HF trial, or in the MOCHA or PRECISE trial, we never used beta blocker in such a stage, and always we want so that the beta blockers can be started. First, we dehydrate the patient with IV furosemide or torsemide along with MRA and other things. Now, SGLT2 inhibitors, etc. also we are starting very early in the treatment of acute heart failure. But for beta blocker, we have to wait a little till the patient is euvolemic and the patient is asymptomatic from acute heart failure symptomatic status. And I would really appreciate what you told regarding sodium, that trial, 1500 milligrams in HA trial. Dr. Fuster was telling 2 days back that how practical it will be, that is difficult to judge, especially in an Indian diet. Because in Indian diet, of course, we sweat more, and the humid atmosphere, we have loss of lot of sodium loss automatically. But whether it will be feasible in any of the diet is very difficult to comment about it. What is your take on this message?
I was going to present the sodium HF trial, but I needed to find room to include some of the other trials, so I just deleted that.
Okay.
It was an interesting trial. I mean, I try to remember now, about 1,800 patients randomized to 1,500 grams of sodium versus normal diet. There were trends to changes in KCCQ, but no difference in major outcomes. Now, I think one of the difficulties is changing diet is actually extremely difficult. So it's very hard to ascertain, how much difference there was. But the other issue is that giving a low sodium diet to very many heart failure patients probably includes a few patients where it's really beneficial, and many, many other patients where it really doesn't make much difference. So I think most of us would believe, despite the trial being neutral, there was a small improvement in the quality of symptoms. But I also believe there are probably a selected number of patients with very severe recurrent congestive heart failure where low salt diet can be a useful adjunct, but there's no evidence it needs to be given routinely to all heart failure patients. So I think that's clear. And your point about temperature, loss of sodium in the salt, different regional diets, when diet changes when people go on holiday and they eat out at restaurants more. So all of those things make doing a trial with dietary intervention extremely difficult.
Yeah. Thank you, sir. And I think mavacamten is the hero molecule of this ACC meet. And we saw the Valor HCM trial. And again, Fuster was commenting that in majority of the center world over, that it is not available. The myectomy or the alcohol ablation is not available in many of the even intervention centers. That too is valid also in India, and I think also in Europe and many American centers. So that being the situation, I think mavacamten is a very good value addition to the present treatment of this HCM patient. It reduced the necessity for going to any operative procedure by 77%. It was 77% and 13% with this molecule. So this is a very important molecule. And not only that, they commented that every 4 weekly they did the echocardiogram, and as you mentioned, sir, all the parameters were reduced. The NT-proBNP, NT-proBNP dropped from 750 to 150, and also TROP-I, though not significant. KCC score improved, NYK class improved by 1, which is significant, 1 to 2. And the dose finding study was very important in the other arm, being pioneered by Dr. Valentin Fuster. That is the HCM, this is the Valor LT study, where he found that we can reduce the dosage significantly in some cases, and that the dose finding study showed, and even we can discontinue, because in 5% of the patient, there was disastrous reduction of the ejection fraction, which was not desirable, and therefore it had to be discontinued in 5% of the patient. And the doses could be reduced at different times, means 10 weeks, 12 weeks, by periodical assessment of the echo and the NT-proBNP parameters, and also the clinical status of the patient. So I think it's a very important value addition to the treatment of HCM, though the average mortality per year is very low, 1% in cases of HOCM, but sometimes it rises when there is significant gradient. And the gradient was also reduced both at rest and post-exercise. So these are very important. And this LT study of this mavacamten is also very interesting. And lastly, regarding the diamond trial, we don't have this molecule, sir, patiroman. but hopefully it will come to India and China soon. And it is very interesting to note the data, because we have been long feeling that when we can't add this ARNI or the RASI others like ACEI, ramipril or enalapril, is very difficult sometimes to treat the patient, and we have to go for, like in CKD patients, we have to go for hydralazine and isosorbide dinitrate in a high dosage, and that is effective also in Indian population, what we have found. But when paturemia comes, there is another molecule which is available, but no study with that one. And none of the molecules are available in India. It's very interesting, and we'll be waiting for this molecule so that we can add some AC inhibitor / ARNI or MRA like spironolactone or eplerenone, even not in an adequate dosage, in a dose which is acceptable to the patient. So I think this is a very important study, and you were in the steering committee. So can you tell us in little detail how much of MRA and how much of ARNI you could give in such patients, where the value suppose was 5.4 or 5.5 milliequivalent of potassium?
Well, during the run-in, the attempt was to optimize the RASI up to the full guideline-directed dose, and that went up to 50 milligrams of spironolactone or eplerenone. And about 85% of people actually could get up to the full dose. And then there was a significant benefit in terms of number of patients who can maintain full dose of MRA. We did a composite score of the dose and number of RASI drugs. So I can't give you exactly what percentage of patients, but that was a significant benefit in terms of the number of patients achieving a composite of dose times, whether they're on both an ARNI and an MRA, an ACE inhibitor or an MRA.
And lastly, regarding the MPulse trial, like the other trials with empagliflozin, it was found to be very useful this time in acute heart failure patient. The KCCQ score improved by all means. You have shown all 4 different groups of measurement which have improved. So as usual, it has proved to be very useful. But there was no mortality data, I think, because the numbers were also small.
There was a trend. I think it was 7.4% versus 4%. So the benefit was there. It was part of the composite clinical, but it wasn't big enough or long enough to prove it separately.
Yeah. Thank you, sir. Thank you for your beautiful presentation.
Dr. Angel, please,
Yeah. Thank you, Professor Coates, for that excellent presentation. Enjoyed your presentation. Just want to make 2 points. One is the use of sorbitrate hydralazine combination, though is referred to in the guidelines that is used in the African patients. We use it quite often in India. And as you know, that SGLT2 inhibitors are contraindicated in pregnancy and lactation, and they're not much of in reference to the heart failure in pregnancy treatment in the guidelines. That is one. Secondly, mavacamten, as you mentioned, I think the study was small number and a short duration, and you have to do frequent monitoring to adjust the dosage. That may be one of the limitations. Then the next point I would like to make is probably the dual SGLT2 inhibitors, that is SGLT2 1 and 2 inhibitors, sotagliflozin, may be better than SGLT2 inhibitor alone, because that SCORE study showed that there is benefit in all the cardiovascular events, including stroke, and it could even benefit in patients who have very low eGFR. So these are the 2 points I just wanted to make, Professor Coates.
Okay, well, I totally agree with you. Certainly for the first 2, I'm not so certain about sotagliflozin. As you probably know, the sponsor ran out of money because its partner pulled out, so the trials were stopped early. It was still very positive, so I'm not saying it's not an effective drug. It's just I'm not sure when we're going to see it available. The SCORE trial was the bigger one. The SOLOIST WHF was relatively small, but still had powerful results. No one really knows whether the type 1 receptor, which is in the gut rather than the kidney, adds extra benefit. I think it's quite plausible that it would. The SCORE trial was in CKD, but there are other trials. DAPA-CKD had a very similar result down to GFRs of 15, and we expect EMPA kidney also had a positive result. It was stopped early due to benefit, but hasn't been published yet. So I think the SGLT2 inhibitors do definitely benefit significant chronic kidney disease right down to low GFRs. I would love to see sotagliflozin available, but I'm not sure whether we will see it commercially or not.
I would like to bring for the point of renal denervation. I mean, when renal denervation first came into being, I don't know, maybe 10 years or more before, we all sort of jumped into doing that as interventional cardiologists. But then suddenly all the negative trials came and it died down pretty much. Now, I think all the recent trials are again showing renal denervation to be important. In practical terms, it doesn't seem to reduce the number of pills too much. It seems to bring down the blood pressure to some extent. So in practical, which patients would you select for denervation? And in the studies, from the studies that you presented, what is sort of a practical guideline to denervation?
Yeah, look, interesting point. I mean, in old-fashioned English terms, we used to have this idea of new treatments went through 3 phases. Panacea, where everyone thought they were fantastic. Poison, where people said they're bad. And then pedestrian cure, their role became established. And I think renal denervation's going through that phase. I personally think it should be reserved for patients with difficult to control hypertension, resistant hypertension. It's not so profoundly effective in terms of major outcomes that it needs to be recommended for large numbers of people, and probably it never will be for very large numbers. I think it's restricted to where there are difficulties with drug management. I think this is a better trial. Trials with sham procedures, trials that use 24-hour blood pressure monitoring are clearly better trials than the early ones that didn't have those procedures. But guidelines are still recommending it only for selected patients.
Also, the denervation, which used to be early, gone into denervation of the branches, which also makes it more effective as a total denervation. So I think
there are many different technical variations, and it's difficult to quite know, how much and how you establish that you've effectively denervated the kidney. That's a tricky bit.
Yeah, it went to 360-degree denervation, because the Medtronic one, catheter previous one, it used to denervate in 3 or 4 planes, but it was a 360-degree phenomenon. And at least there are 9 or 10 catheters available in the market now on an experimental basis, of course, which are as effective as this one. So a volley of, these catheters have come, and the main difference with the previous trials is that it could not cause cutting the sympathetic nerves endings by 360-degree. Now they are being able to do it around.
So you couldn't take over all the trials, obviously, because of shortage of time. The one trial which interested me was the Pacman-MI trial with bringing very low LDL levels with PCSK9 and intravascular imaging, which showed dramatic reductions of the lipid core and thickening of the fibrous cap. And that's been shown from Monash University by Professor Stevens, where he did the Huygens trial, which showed the similar thing. So what do you feel about this very low LDL with PCSK9 in terms of actual regression of coronary plaques? Where do you think that is heading?
I think it's attractive proof of concept. I don't think any regulator is going to approve a drug based on plaque morphology because they're looking for clinical benefits. So I think it gives encouragement that we perhaps should look at major outcomes, but that will be very large trials. So I think at the moment it's still in the hands of more experimental treatments. I don't think it's got to the stage of routine clinical practice.
No, but if you look at it the other way around, the Fourier and Odyssey already looked at the endpoints of clinical which were beneficial. And now we are sort of seeing the proof of concept as to why the clinical benefits were. So it's sort of interesting that you got this cardiac imaging and you got the clinical endpoints in different studies, with the clinical endpoints coming first and then the pathophysiological changes coming after that. So it was
in different settings, but you're absolutely right. I mean, it's an encouraging finding. Clearly, we'd like to know what the clinical impact of that is.
Professor Iyengar, any points you would like to make?
Yeah, I think that study you mentioned, that was the multimodality imaging study, and very impressive findings. And it all shows that lower the LDL, better it is, and earlier to start it, better it is. That all of us accept. There's no ambiguity about it. And what we should aim at is the LDL cholesterol goal. So achieve that goal. You may achieve it only with statins and ezetimibe or bempedoic acid. In case you don't achieve it, then you go for PCSK9 inhibitors.
Dr. Coates, I would like to also bring forward the heart failure sequencing, because there's a lot of talk about use this drug first, use that drug first. Is that now over, the whole concept of sequencing this drug and that drug? Because I think ACC now makes it quite clear, use all the drugs. So what is now the sort of accepted sequencing norm?
Yeah, it's difficult. If you read the guidelines, they're not actually saying what sequence. I mean, in the past, they all had sequences. Now they all just list the 4. But you actually have to ask people, so, well, what is the order? And you get very sort of vague general answers. What I say is that we no longer have a pathway that tells you which drugs to start first. We have a destination, which is get to all 4 foundational drug classes on board, at least at some dose, as quickly as possible to be done safely. And I say there are so many variations in patient factors. There was a very interesting paper by the Heart Failure Association with Rosano as first author looking at patient profiling. And it picks out that simple things like measurements of blood pressure, heart rate, presence or absence of CKD, heart rhythm, will determine a preference towards starting one class versus another. But the ultimate aim is to get all 4 on board. And I'd personally like to see that achieved within a few weeks, 2 to 4 weeks maximum. But I would take the patient case. If they're slightly congested, an SGLT2 inhibitor is a good one to start with. If they're not congested, beta blocker may be better. If the blood pressure is low, clearly it's very difficult to start an ARNI. You might want to start an SGLT2 inhibitor. So I honestly say, bring the art back into the practice of medicine and look at your patients and based on their normal physiology, their blood pressure, their heart rate, their renal function, potassium level, you can decide which is the drug you will start first and how quickly you can add others.
In the Diamond trial, Patrumor obviously seems to answer one of the big problems of the potassium rise. But you mentioned you could almost reach a full dose of all the drugs in the trial. And yet we find blood pressure problems very, very much problematic. We just can't seem to adjust a dose with the BP falling. So
well, we did have inclusion-exclusion criteria that excluded patients with very low systolic blood pressure. So yeah, it's not an all-comers, it was selected patient. But it really surprised us how many people could tolerate full dose RASI when you really tried. In routine practice, people don't try, but in a clinical trial, then they're constantly reminded to keep trying. So I think what this result shows you that selected patients, you can achieve it, but that in practice, we probably don't bother really pushing the RASI dose.
Sir, what was the average dose of patidomere used in this study? Because you were in the steering committee. What was the main dose?
I'm trying to remember what that was now. I'll have to look that up. I can't remember what the average was. I might be able to find it, but yeah.
It's okay. Dr. Anger, yes, please.
Yeah, Professor Coates, in EMPLE's trial, coming to SGLT2 inhibitors, we all have read that SGLT2 inhibitors are probably more beneficial in Asians. Asians respond much better to SGLT2 inhibitors. But when you looked at the KCCQ scores amongst the Asians, and it was rather not beneficial. Was it because of a small number of Asian patients, or is there any truth in that?
Could you just say that again? I just missed part of the question.
SGLT2 inhibitors, it is being reported that Asians respond better. Now in EMPLE's trial, whereas it is not so, I mean, they have shown no improvement in the KCCQ. Probably was it because of a small number of Asian patients or any other thoughts?
Yeah, I think it's a really difficult area. We don't, I mean, my view for subgroup analyses is they've got to be pre-specified and they've got to have some prior hypothesis that you test, because we've seen in multiple recent trials, you sometimes get one region or one ethnic group that's different. but we don't really understand why. And there were relatively small numbers. Another point that's very relevant for this audience is that the group of Asian sometimes refers to East Asians. Sometimes India is put into the Asian bucket. Sometimes they're put into other countries, including South Africa and Australia, New Zealand. So even the racial differences, they're really not consistently and accurately done. I personally I wouldn't trust those differences being reliable.
When you talk of CRT and ICD, suppose you have a patient where CRT or ICD is indicated, an ischemic cardiomyopathy patient, would you have a particular duration of time where you would wait with the drugs to see for LV improvement? So is there any sort of criteria being now suggested that please wait for 3 months, 6 months with the treatment, full 4 doses of treatment before you go for CRT?
Yeah, I mean, most guidelines are saying it's at least 3 months because that seems to be where the benefit is. Where it's tricky is if you haven't got to the full dose. We know from registries that it often a year later you're still not there. So it's the point at which you say, look, I've now tried the best I can now with 4 drug classes rather than 3, but you can get improvements in ejection fraction. So I think the consensus is, once you have done as much as you can with drug treatment, wait 3 months and then make the assessment.
Yeah. It is in the guideline also, sir, waiting for three months.
Yeah, so I think our transplant surgeons say the same thing, that people where there's sort of no option, they're waiting for the heart transplant. It's not that like a CRT you could put the next day, but the transplant you can't do the next day. And many of these patients, while waiting for 3 months, 4 months, for transplants, found themselves improving and getting off the transplant list. So I think sometimes waiting might be good for these patients and they may avoid a transplant. So I think these drugs have made a very dramatic difference. So if there's any last point from Dr. Iyengar or Dr. Kale, otherwise we've come to the end.
Sir, I have a question to you, Dr. Coates, that there was a lot of discussion regarding the side effects of mavacamten. It was a very good drug. In some 9% of the patients, it produces NSVT or something like that. So what is your take on that? And many patients had nausea also. But what is your take, sir? And in 5%, there was disastrous reduction in the ejection fraction, more than what we want. So what is your take on that point?
Yes, I mean, there were side effects. I showed a slide, but the numbers are relatively small, 56 versus 55. I pointed out the fewer non-sustained VT. The only significant excess were rash and nausea. But as you point out, we've seen in the discussion, there was fatigue, but falls in ejection fraction, they're a little bit unpredictable, and there seems to be variability in dose response. So I think it's still very much an experimental drug. And I think we just really need to learn what are the features that indicate a high versus low response to mavacamten. Hypertrophic cardiomyopathy as well is a highly variable presentation. So I think we're a long way away from saying there's a standard recommend dose. I think we need to do it. And it may be one of those drugs that's very carefully titrated on an individual patient by patient basis.
And sir, there was no clear-cut mention, or maybe I have missed, that the usual drugs which are used for HOCMs like beta blockers, diltiazem, then procainamide sometimes. What was the use of these drugs along with mavacamten? Was there any drug-drug interaction?
Yeah, I don't know. I don't have any more of the details other than what was presented. I haven't seen an analysis of interactions with background medication.
So I think we'll close the session. So I think you're probably waiting to go back to sleep. I think middle of the night for you, Professor Coates. So for my friends, I think we'll all agree. That
just one thing I'll fill in. There was a question about the dose of patiromer. So they're 8.4 gram packs, and they started on 3 packs a day, and then when stabilization was down to 1 pack a day, so 8.4 grams per day.
Is it an expensive drug, Professor Coates?
What's expensive? It's a sort of standard price for a new drug. I mean, it varies by country, so I really wouldn't be able to say what it would be in India. That's market by market.
Yeah, because treating heart failure is good, it prolongs life, but it certainly gets very expensive for the patient with all these new drugs.
Yeah.
So,
I mean, it is an enabling therapy. It's a supportive therapy. I mean, I would imagine that it's not going to be priced at ARNI levels. I would imagine it would be lower than that when it first came in. But, you know, that's based on the sponsor's choice.
well, thank you very much, Professor Coates. Indeed, great pleasure to hear from you. And we had a wonderful discussion, and I think we are all up to date now on the ACC 2020, and we look forward to further trials. So thank you so much for being.
And I hope you might join us in Madrid for the Heart Failure Association meeting in May. But
okay, sir. Thank you, sir. Thank you.
Okay, nice to speak to you.
Excellent lecture. Thank you, sir.
Thank you.
Over to the sponsors for the thanks. Anybody wishes to say?
Yes. So on behalf of Acumentis Noveltis division, sir, thank you very much. We had almost about 900 delegates who joined this ACC Konnect initiative from all over India. And let me express sincere gratitude to the respected chairperson for participating in this program, despite their busy schedule, Dr. Jamshed Dalal, Dr. Diman Kali, Dr. S.S. Iyengar, and to our esteemed speaker, Dr. Andrew Coates, for consenting to be a part of the program, despite his very hectic engagements all over the world. It indeed was a very enriching presentation and a very engaging discussion with chairpersons. In the same breath, sir, let me also thank my entire sales team from my Noveltis division for dedicating their time towards disseminating this activity in the interest of continuing education and for the benefit of medical professions across India. And finally, let me thank our CEO and the senior management team from Acumentis for supporting this important initiative of ACC Konnect, sir. So thank you so much for being with us. Thank you so much.
Bye-bye.
Thank you.
Thank you so
Bye,
much.
everyone.